Welcome to the CMS Quality Conference and today's session on who can save patient safety. This is a view from the patient perspective, and their comments are theirs, not necessarily those of CMS, but a vital conversation on the critical topic of patient safety. I'm Dr. Michelle Schreiber. I'm the moderator of today's session. I'm a primary care physician by background, a former chief medical officer, chief quality officer, and patient safety has been of utmost importance to me for many years. I'm currently the Deputy Director of the Center for Clinical Standards and Quality at CMS. Thank you so much for joining us today. Here is today's agenda. First, we're going to do welcome and introductions. We're going to talk a bit about the session objectives. Then we're going to go to our presenters who are going to talk about reprioritizing patient safety and their call for action around transparency, patient and family engagement, and oversight and accountability. Next slide, please. We have three objectives today. First is to share practical solutions for safer care that have their genesis in the stories of patients and their families. Second is to better understand how patient safety activists are re-energizing the National Patient Safety Agenda. And finally, to identify important opportunities to improve patient safety with a focus on transparency, patient and family engagement, and accountability and oversight. Just as a bit of background, it's been over 20 years since the first Institute of Medicine report documented the importance of patient safety, and that far too many patients and their families have been harmed from healthcare error. After decades of work, patient safety had shown some improvement, although the Office of the Inspector General noted that pre-COVID, a quarter of Medicare beneficiaries were still experiencing harm. During the pandemic, data published by the CDC and CMS showed a dramatic worsening of patient safety with increased risk rates of healthcare infections and other safety events. Today, we will be hearing from patients and patient advocates about practical approaches to safer care from their perspective. We also recognize that the President's Council of Advisors for Science and Technology are currently evaluating patient safety as a focus for executive action, and we're awaiting their recommendations. Next slide, please. So with this background, it's my pleasure to introduce you to three of the founding members of Patients for Patient Safety, the United States chapter. Patients for Patient Safety US is a network of patient safety champions and advocates who work towards implementation of the World Health Organization Global Patient Safety Action Plan. My introductions are about a high-level background, as each presenter has extensive experience and long-standing dedication to improving patient safety, and we are just thrilled that they are here today. The first presenter will be Marty Hatley. He hails from Chicago, and his interest is the role of patient safety and family members as co-creators of patient safety solutions. In 2021, he co-founded Patients for Patient Safety US. He also serves as the president and CEO for Project Patient Care, a nonprofit organization based in Chicago that's dedicated to using the voice of the patient to improve care. His past experience as a civil rights attorney, a malpractice defense litigator, a lobbyist, and a coalition builder prepares him well for these advocacy roles, and he works extensively with consumers and other organizations to foster the cultural shift necessary to support a patient-centered, systems-based approach to the delivery of healthcare. He has served on numerous quality and safety committees, including with AHRQ, the Agency for Research and Healthcare Quality, the CMS Partnership for Patients, the National Quality Forum, the World Health Organization, and the Joint Commission, just to name a few. Our next presenter is Carol Hemmelgarn. Carol is from Denver and also a co-founder of Patients for Patient Safety US. Carol was driven to the field of patient safety after she tragically lost her 9-year-old daughter, Alyssa, as a result of multiple medical errors. Her passion resides in transparency and communication after medical errors and the aftermath ensured by providers, patients, and families when medical harm transpires. Carol has a master's degree in patient safety leadership from the University of Illinois and a second master's in healthcare ethics from Creighton University in Nebraska. She has worked in healthcare for over 30 years and is currently the Senior Director of Education for the MedStar Institute of Quality and Safety, as well as the Director for the Executive Master's Program for Clinical Quality and Safety and Leadership at Georgetown University. Carol is also deeply involved in patient safety work across the country and sits on multiple boards, panels, and collaboratives, including the Leapfrog Patient and Family Caregiver Panel, the Pediatric Sepsis Outcomes Collaborative at Children's Hospital in Colorado, and the National Quality Forum. And finally, Colonel Stephen Coffey is a career military officer in the United States Air Force. Thank you for your service. His passion and purpose for improving patient safety began when a delay and ultimately misdiagnosis of a metabolic condition in his newborn son, Stephen Jr., required a liver transplant at just 8 weeks old. Colonel Coffey has a long and distinguished career in the Air Force, including working with the National Security Agency, the Joint Chiefs and Headquarters Air Force, and as a military aide to Presidents George W. Bush and Barack Obama. He has a BA from Morehouse College, a Master's of Arts in Legislative Affairs from George Washington University, and a Master in Clinical Quality, Safety, and Leadership from Georgetown, just to name a few of his degrees. He joined Carol and Marty as a co-founder of Patients for Patient Safety US and was a charter member and the first community chair of the MedStar Georgetown Patient and Family Advisory Council for Quality and Safety. As with the others, he serves on multiple committees as a technical expert panel and foundations in support of patient safety. Please join me in welcoming our incredible distinguished panel as we also thank them sincerely for their dedication to patient safety. Let me turn the session over to Marty Hatley.
Thank you, Michelle, and thanks to CMS for giving us the opportunity to address this conference, which I still think is the largest quality and safety conference of the year in our nation. So it's an honor to be here. And I'm here to, as you said, to talk about what patients and family members bring to the table. And we are activated now in calling for reprioritization of patient safety as a top public health issue. And I say that we're changing our rhetoric from being patient safety advocates to being activists because we're alarmed. The failures in reporting of patient safety events still occur 20 years after the report that you mentioned, To Err is Human, which was a call to action to make this a top public policy priority. But 20 years later, we still see and experience a deny and defend culture after harm occurs in many healthcare organizations, even when we know or suspect that internal root cause analyses reveal the care was unsafe or substandard. And while we've made strides in transparency with public reporting of hacks and other patient safety information, which we really appreciate and value, we believe that much of the data the country could use to learn and improve is still siloed or hidden in some way and ineffectively used. We're not here to cast blame. In fact, I empathize when the legal system selectively casts blame, criminally or civilly, on healthcare providers. And I long for a healthcare system that moves beyond blame to systems-based learning and more restorative and healing approaches to justice the way several other countries do. But this requires open and honest communication, reporting, and data sharing. And we still see providers fighting transparency, more intent on managing the risk of liability exposure, it feels, than they do on the risk of harm to us and our families. And we as patients and families just can't support, that kind of risk management at the expense of really putting the risk of harm to patients and families first. I want to say a little bit, Carol's going to get into this, but I want to say a little bit about the PSO program, which was designed more than 15 years ago by Congress to serve as our national learning system for patient safety. So more than 15 years later, we have 90 PSO organizations in this country, but only 3 contribute their data to the National Patient Safety Database that was also part of that scheme. And I think there was an anticipation that all of the PSOs would share data to be a robust part of the national learning system. And there may be improvement going on in those 90 plus silos, but if there is, we can't see it. And it's not manifesting in the data on improved patient outcomes. A 2021 National Academy of Sciences report that looked at the effectiveness of this program. It was a look back mandated by Congress. The authors observed that progress in patient safety was at a standstill in the United States, and that continuing in the current trajectory would not produce better results. So recent reports that you mentioned, Michelle, by the OIG, researchers, even liability insurers, all point to a lack of the progress that we expected to make in improving outcomes in any domain of healthcare other than anesthesia, which is our true success story. I would say that patient activists like Carol, Stephen, and me have seen progress, so we don't want to minimize the fact that it's happened. And we've certainly seen some systems and hospitals step up. And we saw for a time most hospitals and systems step up, focusing on reducing hacks, engaging patients and families, and sharing lessons learned in the nationwide collaboratives that CMS, HRQ, NQF, and the private sector invested in during the Obama administration. But we've also seen that progress and attention drift since then. And COVID-19 underscored the gaps in patient safety, health equity, and health system reliance that we were hoping we were making progress on. Next slide, please. So this concern brought 10 of us together a couple of years ago to form the US branch of Patients for Patient Safety, which is the WHO network that Michelle mentioned. And we are led by patients, family members, and the 10 people you see here, but we're open to anybody, including health professionals, policymakers, anyone who's passionate about achieving patient safety goals. And we are part of an international network, although we're focused in the US. So here are my co-founder colleagues, two of whom are with us today. Next slide, please. One of our first actions was to write an article with a provocative title, Who Killed Patient Safety? Our goal was to restore a sense of urgency about patient safety to the national debate and to really challenge leaders in government and the healthcare sector to reprioritize this issue. When that first IOM report came out 20 years ago, polling showed that 51% of Americans were aware of it. It was that much in the news. It was that much prioritized. There was a Rose Garden ceremony. And we feel like we've really lost that prioritization, or had lost it, which is what prompted us to read this article. The article got a lot of attention, so we believed it helped do that. It's really led to the kinds of dialogues and the kind of opportunities we have here today to talk to you. Next page, please, or next slide, please. Simultaneously with writing that article, we also began reaching out to government agencies, nonprofit organizations, and for-profit stakeholders with the offer to collaborate in advancing patient safety and health equity as top policy priorities. This is very much in line with the World Health Organization's Global Patient Safety Action Plan, which recognizes that all stakeholders, whether you're private or public, state, federal, local, have roles to play. But with that said, it really does emphasize the role that policymakers at the federal level or the national level need to play as necessary leaders. Next slide, please. In the WHO sort of lexicon of terms, people who are activist members of our network are called champions. So we had 10 champions start this, but 10 is not enough. So our goal is to grow this network, and we hold orientation sessions 3 times each month for people who are interested in joining us and becoming a patient safety champion. And again, it's structured to be led by patients and families, but anyone who's passionate about advancing patient safety can join us as a champion and participate in our working groups, our listening sessions, and our other work, which has included some really wonderful dialogue with policymakers at CMS and other agencies. Next slide, please. Here's our model of collaboration. It really is to identify patient safety and health equity issues with our champions, with the lived experience of the people who are part of our network, to identify organizations that have levers for change, and to approach those organizations with offers to partner and to co-create actionable interventions that close gaps and overcome barriers. And then we implement and innovate. Next slide, please. This process has generated 3 domains of ideas and recommendations that are our priorities and that we're really here to talk with you about today. And those domains are transparency, accountability and oversight, and patient and family engagement. We think these are drivers. These are change drivers of the kind of transformation we want to see in our healthcare system. So with that said, I'm going to turn this over to my colleague, Carol Hemmelgarn, to talk about transparency.
Well, thank you. So I first want to start by telling you how I want to go through this. And I sort of look at this as a story of how when harm may happen to patients and families and what is it that we need and want. But before I do that, I want to orient everyone on what I think transparency is, because transparency is a word that is thrown out there a lot right now in healthcare. And if someone were to say to me, how would I describe transparency to my children? I would say it's like cellophane or saran wrap. What you see on one side, you can see on the other. Everything is visible. It's apparent. So taking that mindset, the one thing that we realize in healthcare is always a learning entity. And that's the beautiful thing about it. We keep realizing there's opportunities for improvement. And so as I bring up some things today, I want to be part of that. I want to be part of giving ideas for solutions, not that we're just ducks here quacking on noise, but rather we're eagles that are here soaring with healthcare, trying to offer ideas and think outside the box. So the first thing that happens that we have to talk about is reporting. We know that reporting starts at the local level. We know there's issues with reporting. There's a plethora of literature out there on all the barriers. But that's why we've gotten better with things like global trigger tools and AI. But that first barrier is just getting the reporting in there. The next thing is that who reports? So it's funny, each organization, maybe it's risk management that reports to the state health department, maybe it's infection prevention, maybe it's safety. But we realize that there's multiple players that may be reporting to multiple different entities, whether it's the health department at your state level, who's then reporting to CMS, who's reporting to the accreditor. So we know there's many breakdowns and barriers that happen in that reporting structure. But there was something that Dr. Schreiber said in a recent call that got me thinking too, and that is around the definition or taxonomy of harm or medical errors. What we realize, there's a few standard definitions out there, but each organization can be using something different. So unless there's sort of consistency, how when we're getting that data, are we looking at the same things? Are we defining things the same way? And I think that's really something that we ought to be looking at more and more across all organizations, that we're using the same vernacular and definitions. One of the other things is that I really spent a lot of time thinking that we know that conditions of participation is difficult and doesn't work for everything. So who else can be held responsible? Who else can take those next steps to make sure reporting is done and it's done up the chain of command? And I really think this goes to leadership and this goes to governance boards that I don't think we've done a great job. And that is, to me, when there are events, the CEO ought to be the one that's making sure it's reported to the state level, making sure that it gets to CMS, making sure it gets to Joint Commission, whoever the responsible areas are. And that in order to make sure that happens, it should also be the responsibility of the board, of the governing boards, to hold leadership accountable for these sort of things. I think we've had a lack of leadership when we have seen events recently occur across the country, and leadership needs to step up. We have CMS, we have the other entities that are pushing back, but we have to hold leaders accountable. And there has to be a structure from the board aspect as well, taking part in some of this. So then I want to move on to the data aspect. As Marty said, we have all this data out there and we're not sharing data. And it's a shame to me when the PSOs have really become more of a protective entity than an entity that is really about learning and about sharing information so that we can make healthcare safer and equitable across the board. So how do we do that? Maybe AHRQ plays the role in pushing that, or is it patients and families that really step up there and say, this is our data. And yet it's not being used appropriately. One of our colleagues, Beth DeLeolum, gives a great example that there's solutions for patient safety. 115 pediatric hospitals that belong to Solutions for Patient Safety. And there's the Children's Hospital, PSO. They do not share that data with Solutions for Patient Safety. How can we not be learning from that? The other request that we have is that while the HAC data is collected, we believe that there should be other avenues for collecting data just besides the HAC. We know that there's other harms out there, and how are we collecting that data and getting that data out there as well? The next thing that I want to address, which is near and dear to my heart, and that is communication and resolution programs, or what I really like to refer as reconciliation. Because please understand, there is no resolution typically for harmed patients or families. AHRQ some years ago, 2016, created the Candor program, which I was part of, and it's a great toolkit. It's a great resource for organizations to use, but organizations need to implement a stable, consistent program that is across harm, that you don't get to cherry pick which harm events go through this process, that every harm event uses the same process. What I'm really very grateful to see, and myself and Marty Hatley, who's on this call, is that there is a structural metric measurement going on right now, and in the patient safety space. And part of that, we're looking at our communication and reconciliation programs. And with this, it's that first step of having organizations making sure they have these implemented programs. And while it may be just an attestation, we know that sometimes these structural measures start out this way, and the end goal is to really take it further and perhaps attach incentives or penalties if they don't implement structures like this. And why are these programs so important? Well, the first time when patients or families are harmed, it's unintentional. But it is absolutely intentional when organizations aren't honest and fair and upfront and truthful with patients and families after that. Those are intentional harms, and that's what we need to stop, because patients and families need to heal and move forward after these types of events. And along with that, we are really asking organizations to not harm again by attaching gag clauses. Gag clauses are just another slap in our face saying, we did this to you, and by the way, you can't talk about it. I can tell you, I have many colleagues and friends, and they don't want to talk about the money. They don't care about the money. Sometimes they don't even take the money. What they don't want to be told is that they cannot talk about what happened to them or their loved ones. And gag clauses stop that, and gag clauses stop learning. And we need to continually learn in healthcare. And the final thing I just want to say that sort of takes this story to a conclusion is that the 21st Century Cures Act is out there, and that is about making sure that patients and families have access to their medical records, to knowledge, to power. And what is so important about this, if I close this circle, is that when patients and families can see their records, they can many times mitigate potential harms because they can see things in the record that maybe aren't right, or reporting issues or things they can share. So we need to make sure that organizations are opening up and making the records available to patients and families, because this is where we work together and we help mitigate potential diagnostic errors, risk, and we learn what problems need to be addressed and need to be fixed. With that, I'll turn it over to you, Marty.
So when patients and families tell us what their problems are with patient safety, they describe something like this, which is the National Patient Safety Board Coalition's depiction of our current ecosystem of healthcare oversight. And in patients' words, we don't know who's in charge. We don't see anybody in charge, and we don't know where to go to make sure that our experience matters. We don't know, we want to be part of learning. We want to be part of co-creating solutions. We want to know that it's not going to happen to another family the way it's happened to us, but we literally don't know where to go. And I think that's a valid point. I mean, there is so many different stakeholders that have to be coordinated. And one of the reasons that we're calling for, more federal leadership and oversight is because that coordination role, again, we've seen it happen sometimes, but we think it could happen a lot more. I also just want to comment a little bit on what Carol said. It does strike me as maybe a problem for us to wrestle with, just kind of a strange paradox that we spend so much time defending against transparency, and yet the number one reason that patients tell us they sue is because they need to do it in order to get an answer. So we're almost funneling, by our lack of transparency, people to litigation, which is one of the things that we just know is not a good experience typically for anyone, and not a good cost-effective experience. So there's a lot we can do, I think, to better tackle this problem of oversight and coordination of oversight and transparency. Next slide, please. So when we think about and talk about accountability and oversight with our partners and with our champions, our priorities have become pretty clear from the very beginning, and that is to reassert patient safety as a national priority. And I have to say that, the article that we wrote that I mentioned before took 9 months to get published. In that 9 months, we established really effective conversations with CMS, CDC, ONC, OIG, a number of organizations that were eager to hear our point of view, and I think acknowledged from the beginning that this was a priority that had drift. Dr. Schreiber, you even mentioned that in your comments, and I have to just thank you for being a leader in this space, along with several of your colleagues, and really saying, yeah, we need to be making better progress than we have. We have lost progress. It is time to reprioritize that. So we feel like this is happening. We also really see this work on patient safety be very connected to another high priority of our government, as it should be, which is health equity and the gaps that we have in different outcomes for different populations of people, different demographically defined populations of people, or demographically described. So we see these as two sides of the same coin. We really are here as advocates for safety for everyone, no matter who you are or what you look like or what your abilities or lack of abilities are. We think this federal coordination has to happen at the federal level. I mean, even though we have a split of responsibility for the safety of patients between states and federal leaders, under our constitutional scheme, the real leadership has to come at the federal level, and then the coordination with the bodies on the state level that are in charge of oversight. And then one of the things that troubles us mostly, especially that we're 20 years into this call to action on patient safety, is when we see things like reporting systems that aren't complied with, when we know that there are states that have the right policies in place, they have the right expectations in place, and yet those expectations are not fulfilled. And so we are looking in our dialogue with you all for how we can find the right mechanisms, whether it's conditions of participation, public reporting, contractual levers that CMS and other organizations have, to really get us all to be walking the talk of doing the right thing that we need to do as a community to improve safety. So if we're kind of drilling down to really specific things, we do think there needs to be some federal leader in charge of that coordination thing that I've mentioned 3 or 4 times now. So it could be an office, it could be a czar, it could be a commission, it could be a team, but someone that really has the job in their job description for coordinating across different agencies. And by coordinating, I mean budget measurement and public reporting across all the different agencies. We would love to have some of the data that is parked at different agencies more accessible across agencies to the organizations that can use it to effectively drive safety forward. In terms of accountability, we think it would be helpful to have a national report on patient safety to the US. This could be to Congress. It could be a national report put out by the executive branch or by the person in charge. This would help keep it a number one priority or a top priority for us in the public health scheme. We are strongly in favor of having an independent agency that doesn't have regulatory power. So I want to make that very clear. I want to reinforce that. But there's several organizations in this country that are together working in a coalition called the National Patient Safety Board Coalition. There's an act pending in Congress that was introduced last year that we expect to be introduced again this year that sets up a National Patient Safety Board that is modeled after the National Transportation Safety Board, for which we have a lot of experience over 20 years. And I think this is something that could be a resource to all of us. What I particularly like about this concept is if you think about that fractured ecosystem, this is an organization that could make recommendations, which is what it does. It's an analytic engine that looks at data and makes recommendations. That's all it does. But it could make that to private organizations. It could make that to accreditors. It could make that to regulators. It could make that to patient groups. It could make it to prosecutors. It could go to pretty much any place that that has some responsibility. So I think there is, for those of us that are concerned about, regulations that don't work, reporting systems that are duplicative from jurisdiction to jurisdiction, overzealous prosecutors, this could be a resource for all of the improvement that many of the different stakeholders want to have. We do I think that there does need to be a strong investment in patient safety from a budget point of view at the federal level. And we've seen that happen before. We saw it produce progress. We are strongly in favor of doing anything we can to help any of the organizations, the federal agencies that have this in their scope of work to have the resources that they need to do that scope of work properly. And we're, I think, ready, willing, and able to talk to our congressmen, our senators about making that happen. The structural metrics that Carol mentioned, we think are really important things forward because they go to culture. They go to leadership. They go to the kind of norms that get established in an organization and championed by executive leaders and overseen by board members. So again, I have to just call you out, Dr. Schreiber, for being such a leader on this process, not just in the patient safety sector, but for women and children's health, for seniors, for health equity, for social determinants. It's been very, very gratifying for us to see this level of commitment from CMS to try to get that better information that we need publicly reported so that it can drive improvement and better measures going forward. And then we do want to see strengthened oversight for those situations where there hasn't been compliance with law or regulations or rules. I mean, whenever we have carrots and sticks on the menu, it's always better, feels better certainly to talk about carrots. But when we see organizations that are not reporting something that they're required by law to report, not filing death certificates that acknowledge that there was a medical error that was a contributing cause to death, not talking honestly to patients and families in the way Carol spoke of, we really think there needs to be a stick, or at least the threat of a stick, to kind of drive home the memory that this is something that organizational leadership has to manage. So that's our menu. Those are the things that we'd love to talk to you about in the oversight realm. And if we can transfer to the next slide, as we also transfer to Stephen to talk about patient and family engagement.
Thanks so much for this opportunity. I will tell you that central to what we do, central to medicine, central to providers is a patient. And I think that's sometimes lost, because I will tell you that as an active duty officer who has spent many years in the Pentagon and other military bases, the thing that I often tell people is that going into a hospital is a significant emotional event. When I take people into the Pentagon on a tour and I show them the things that are around the building and the things that are on the walls, I don't generally pay attention to those because I see them on a daily basis, but they are in awe. Similar, when I go to the hospital, it's a significant emotional event. It is something that reminds me that I only go if someone I know is sick or I'm sick. And so the reason I bring that forward is that it really centers us on why we're here. And the inclusion of patients and families is central to making care better, to making it safer. When I think about how we're able to do that, it starts with understanding the patient's perspective and the patient's view, the patient's story. And so I often take my son to the hospital, and we talked a little bit about what drove me to this space of patient activism was him. But I see the entire story, the entire movie. And when I go into a provider's office, I'm telling them the entire movie, but they only see a snippet. And so there's an appreciation that has to occur between providers and patients for that movie, for that perspective. There's an appreciation for what patients bring to this shared decision-making model of how we have medicine, how we have healthcare. And so I think it's important that we remember that in all that we're doing is we have to include patients and families. We have to include that perspective because it is central to how we get better. Understanding that patients bring a sense of insight. Again, when we talk about that shared decision-making, we talk about that piece of understanding the whole movie. There are things that patients and families will see in the health system that are often overlooked because the persons who are in the health system, providers, are inoculated to it. You don't necessarily see some of the challenges that beset the healthcare systems. And so it's important to really recognize that voice, to appreciate that voice, to understand the insights that patients and families bring to how we improve quality and safety within medicine. But I'm a very solution-oriented person. As an active duty officer, I'm very much a solution-oriented person. And the call to action here is really where I want to spend a little bit of time. When we think about how we can actually take tangible steps to fix things, to solve things, it really comes down to structure. And in my mind, it comes down first to leadership. I oftentimes say that leaders are thermostats. They're not thermometers. Leaders set the tone. Leaders set the principles. They set the path forward. They don't just take a temperature to see how things go. They change the course. And if we're going to really be serious about including patients and families and improving care, it matters when we structure our PFEs. It matters that we have explicit policies that require diversity in our PFEs. These are the things that start at, in my opinion, the leadership level, that we set that course and we show there's an importance and there's an emphasis on that patient voice. It matters with how we do reporting. When we think about HCAP scores, those are things that often drive a lot of things in medicine. And so making sure that those scores are now reflective of patient experiences, making sure they're reflective of safety is how we start to really improve the system of healthcare that we're in. So last thing I'd like to touch on is really just how we're able to be more inclusive of patients and embed patients and families in high reliability organizations. The biggest part about patient engagement is involving the patients. I cannot overemphasize the importance of ensuring that you respect the patient voice, that patients feel like they are as much a part of the team in the shared decision-making model as the provider. With that, I'd like to turn it back over to Dr. Shriver for questions.
Thank you. So let's talk. First, thank you to our panelists. I'll say that again, but what an incredible wealth of experience, and hearing from their perspective is so critical. We have a couple of questions that we hear frequently, and I'm going to pose a few of them, recognizing that our time is sort of running out. But again, in such an important topic, let me ask all of you, why is it important to engage patients and families in actually reporting themselves safety events? And how do you foresee that could happen? I'll start with Marty.
Thank you, Michelle. Well, I'm going to start by picking up on what Stephen said, and that is because patients and families see the entire journey. They see things that providers often don't see. They certainly see some of the sequelae of care that happens after a loved one or perhaps ourselves leaves the healthcare setting. So it just completes the picture of information that we can get from patients and families. I also think that where organizations are hesitant to report sometimes because of fear of litigation or fear of loss of reputation, family members are less hesitant. So I think having a portal for them to be engaged in this important active reporting, it builds partnership. It also creates more information.
And Michelle, I'll just add on to that because we so often focus on the physical harm, but there's a lot of emotional harm. And I'm seeing more in the literature about that. And that emotional harm can be the racism, it can be ageism, it can be all the different other isms that go along with that, that nobody captured. Yes, we've been physically, but there's also that emotional component that we can only get if you talk to patients and families about that. So it goes deeper than just the physical harm.
So I think it's really important as we include patients, because patients help remind us that health system is actually an ecosystem, because patients come from many walks of life. And when we're able to bring in patients to be able to help report, to have that voice for reporting, it makes it safer. It reminds us that I can't necessarily say I'm going to prescribe you something with a bias that you've got clean water to drink, you've got good food to eat. Those are kind of things that patients sometimes help remind us in the health system that it's an ecosystem. It is not a standard cookie cutter approach when we're doing diagnosis, when we're giving care. We need patients to partner and really respect that voice as a partner. And that's how we can make it safer.
Thank you. You know, a number of you have spoken on the role of healthcare leaders, the C-suite in particular, in governance boards and safety. How would you anticipate that can be tracked? And what do you think is most important to hold governance boards and C-suite leaders accountable to?
Well, I'll jump in first. I think transparency is a huge driver. So you've heard us talk about, I think all three of us have talked about it. Patient and family engagement gets you to transparency and operationalizes it. But just getting the truth, creating that partnership, believe me, most patients and family members want to be part of change. They want to help the healthcare system, which we rely on so much, be as great as it can be. So it just personally hurts me to see organizations not be transparent when there are so many benefits to be transparent. So I would say that's my number one wish, that we could kind of really get the leadership of organizations to understand the importance and the benefits of it.
I think there also has to be training. You know, I think we get members on these boards and they don't really understand safety and quality. So they have to be trained, but they also, I think, have to understand their role. They have a role, and it is to protect society and community. And so often, to me, how I look at it, if I see a board agenda and finance is the first thing they start, that tells me volumes about what the focus is on the organization. If it starts with safety or quality, that tells me the culture and what the focus is. So we need to educate, and we need to have the right people on the boards that understand the perspective of the patient and family and what is most important to the organization.
Yeah, I think just sort of piggybacking on that, when we think about operationalizing and including those patients and families, really drawing that connection that there is a financial benefit to the hospital system and the hospital when there's safer care. I use a really crude example of talking about Yelp, because word of mouth is always still the best advertisement. But if I know that there's safer care at a hospital, I will beat the doors down to get there, right? So really making sure that we tie it to safer care is better for the hospital. It's better financially, it's better for patients, it's better overall. And that starts with inclusion of patients, that starts with transparency. That's how we get to a safer hospital system.
So thank you. I hope we have CEOs and board members on the line today. You know, you've spoken about patient safety, which is obviously very critical, but workforce safety is also coming up as a really important topic. Do you have thoughts on the role of workers or workforce safety and how patients and patient advocates can actually help workforce safety as well?
So let me jump in first on that one. I think that there is a plethora of patients that would absolutely love to serve a hospital in some capacity. As I sit on the PFAC at MedStar Georgetown University Hospital and with MedStar Health, it's comprised of that patient part is comprised of patients who have sometimes experienced harm, some who just saw a need and wanted to jump in. And so we think about how you can sort of be that buttress, that enabler to help the worker safety. Using patients to also provide another lens is one of those ways. It gives a little bit of respite when you have a patient who's been trained to be able to engage with other patients, to do some of those things that really kind of are additional tasks that providers have to do. So really utilizing those patients and families to also be part of the medical team. Again, building in that ecosystem is one way that we can support.
And Michelle, I'll just add that I don't think you would have any patient or family argue the importance of workforce safety, because we need the workforce and we need a healthy workforce. What I don't want to see is what we do so often in healthcare, and we silo things. So here's workforce safety, and then we jump all over here. Here's patient safety. We have to keep things integrated and not break them out, that one is more important than the other. And that is the biggest thing I want to see. Let's not pit them against each other. Let's make them synergistic, because when they're synergistic, then there's safety for the whole, like Stephen said, ecosystem.
What I'll just add is I think I think they are different issues. I see them as being different issues, but with the same challenge, the common challenge of having, organized workplaces that are resilient and that are adaptable and that invest in keeping the people who are in that workplace, either as users of care or providers of care, safe. So that's really what I would add to what my colleague said.
Great, thank you. All right, one last question, and you only get a minute or so. What is the single most important step you believe that federal agencies can take to promote patient safety, in a couple of words?
I think there has to be somebody in charge. I think there has to be leadership and coordination across the different agencies, state and federal creditors, all of those different bodies that play a role.
I will say that, Michelle, and we can't let it drift again. We have to keep it at the forefront.
I think Marty and Carol absolutely hit it on the head. We need someone that's leading the charge. But we also need leaders at the helm who believe that everyone has a voice and they value that voice. Above everything else, we value the voice of patients, we value the voice of providers, we value the voices of families, because that is our central goal, is of making healthcare safer. That's how we get there. We need leadership, we need to value a voice.
Well, thank you all. As we come to the conclusion of today's talk, I just want to say, first of all, we value your voice. We value the three of you being here, Patients for Patient Safety US, all patients, patient advocates, patient activists, I guess I should call it. And we thank you so much for your dedication and for being here and sharing your perspectives today. Patient safety is something that we do need to always continue to focus on and put front and center. And I think you've brought your messages very clearly to all of us today, and we thank you so very much.